what they would tell their patients. So we're looking at some of those things now. Also personalization of digital intervention. So I currently do have a mobile app that has been tested extremely a lot with Black women. From the formative stages, we had Spelman students create wireframes all the way up to now where it's a functional app, and it has been proven to be feasible and acceptable among Black women. So now I'm at the phase of moving it into the market. And then hybrid models, I don't want to miss that out because we can't throw everything that worked out. So there are sometimes that there will need to be touch points. Everything can't be all digital. So we have to learn how to integrate those things effectively. And then I want to just kind of lay out a little bit of a roadmap here for innovation. If you're looking at innovation and how to include it in community, one, assessment. What does the community want? You're partnering with them. You're talking to them to get that information. Two, development, co-development with the community. Iterative stages where they are constantly informing the technology. Three, partnership. I think that's self-explanatory. Constantly have to be in partnership. Key stakeholders. And then rollout. And then see what you might have to do to keep it relevant as technology evolves. I just really want to highlight some grassroots initiatives, and of course Sister Love, because they're in Atlanta, and I have worked with Design on a number of projects before, but I wanted to highlight their Sister Love van. So in addition to all of the resources they do provide, they also go to the community and provide testing and other things. So those are some of the innovations that we have to do, or that's nothing new. We have had mobile units before, but it was timely. That's what the community needed, and they need now. It's for someone to come to them. So our call to action, we need to advocate for her. I said for her, but with her. That should be with her. We need to advocate with her. We need to educate her. We need to support her, and we need to connect her to the resources, especially in this climate. Digital tools can certainly help to facilitate that. Here are some resources for both patients and providers. And I am going to get out of the way, but this is a nod to the Cmhdre app that I mentioned. I'm going to go through these slides very quickly, but I wanted to show you, this is my pitch deck, and I basically have a persona of Ebony, really talking about what her needs are and why Cmhdre was created. So this is, you have to have your market plan, revenue plan. You want to pitch this because we want this to go out to the market. This is a little bit of a glimpse inside of what Cmhdre was. Aesthetically, it was informed by Black women. And then this is my team. Like, it's definitely through other institutions, Georgia Tech, Morehouse, Emory, we're all working together on this. Thank you very much for your time and attention. Happy to answer any questions.
All right, we'll give Dr. Chandler another round of applause. How many of you were familiar with the tools and resources, some of the tools and resources she shared in the previous presentation? Okay, so we know we're going to go back to this slide deck as we develop our tools and strategies for our practices at home. Thank you, and we're going to have time for questions throughout the panel session, so if you have any or if any arise during that time. Next, without further ado, Dr. Corliss Heath.
Good morning. My name is Dr. Corliss Heath. I am with SAVE Incorporated. I'm the CEO and founder of SAVE Incorporated, a nonprofit education and technical assistance organization. I wear many hats. I'm a medical anthropologist. I'm a teacher, a preacher, a community consultant. I also am a health scientist. My disclaimer today is the views and opinions of this presentation are not those of the HHS or the federal government. They are my own. And so today we will be talking about addressing the housing needs of Black women with HIV. My disclosure: for this educational event, I have no relevant financial arrangement or affiliations with any corporate organizations to disclose, and some of the information that Dr. Chandler has given you as we began, you will see at the beginning of my presentation, so we're going to kind of run through that. So let's look at the impact of HIV on Black women. When we look at the estimate of Black women, the rate of new infections among Black women are approximately 8 times that of white women and 3 times that of Hispanic women, where Black women account for 47% of new infections among Black women. And it has already been stated that in 2020, Black women in the United States made up 13% of the female population, but they accounted for 54% of HIV diagnoses among females. Now, when we look at housing and HIV outcomes, at the end of 2022, overall, the percentages of Black African American women retained in care, which was about 79%, and those who were virally suppressed, which was about 89%, they were relatively consistent with those upon the Rhineland National HIV/AIDS program. However, Black women who retention and care were lowest, those were the ones who were unstably housed. And when we looked at those who, among virally suppressed individuals who were unstably housed, we find that their viral suppression was the lowest. So we need to look at some of the root causes when we begin to look at health inequities and health disparities. When we look at these root causes, often Black women face challenges of engaging and staying in care. And these are due to some of the competing needs of balancing their own psychosocial needs, looking at the needs of their families. And these challenges are further exacerbated when we start looking at structural factors, which includes race, gender, and class. And that also includes inequitable housing. And when we start looking at housing, housing does not stand alone. It also includes unemployment, also intimate partner violence, stigma. And so when we look at all of these coupled together, we find that Black women often have risk of transmission and HIV health outcomes that are worse than other Black women. And so scholars have used an intersectional approach where they look at and they contend that race, gender, and class must be looked at collectively. You can't just look at one without another. You have to look at them as intersecting systems of power. Intersectionality offers this framework for examining how these effects are experienced in one's life, particularly Black women's lives, and how all 3 systems of power interact with one another to produce their health outcomes. And we're going to look at these and see how they produce these health outcomes as we look at housing. So as we look at experiences of Black women with HIV, we ask the question, what does this mean, and how do we consider the experiences of Black women as we consider housing and other health outcomes? Well, first of all, we have to look at Black women with HIV, understanding that their physical, social, and emotional, all these coupled together with the mental, it has an impact on their diagnosis of HIV. These impacts are experienced differently across the lifespans. As we're talking about today, the experiences, they experience implicit bias in healthcare, and most of this is talked about as we see a lack of cultural sensitivity. Healthcare access also comes with certain types of stressors, as oftentimes Black women in general, and then you add Black women with HIV are often seen as invisible. Their conditions, their health issues are not taken seriously. We look at their roles in the community, where they are often heads of households, their parents, their leaders, but even when you have all of these things coupled together with having an acquisition of HIV, individuals look at them from the outside but don't acknowledge what may be going on behind closed doors. And then we have these societal messages of stigma, the shaming, blaming language associated with behaviors and morals. Well, if you had not been, or if you did not do, then you would not be in this particular situation. Oftentimes we have to look at the comorbidities that go along with HIV, and when we look at certain comorbidities, these are other things that also impact other issues and other stressors, as it impacts what we're going to talk about as housing. And then often, although it's the last thing, it's one of the most important things we have to understand, that HIV is more than just a diagnosis. So what is it when we talk about providing care for Black women with HIV? Well, housing is health care. And so when we look at housing, first of all, we have to address the housing situation and the identity and identify the present skills, looking at services to address the intersecting conditions of mental health, substance use disorders, homelessness, housing instability, and also individuals, women who may be coming from incarceration. We have to identify the stakeholders, such as property, private landlords or renters, individuals who can provide emergency housing support. We have to build partnerships with agencies such as HOPWA. And HOPWA, if you don't know what HOPWA is, the Housing Opportunities for Persons with AIDS. These are agencies that can provide and projects to provide emergency, transitional, and permanent housing assistance. We have to be able to teach women to communicate and empower clients to discuss the importance of building these relationships and get them to ask for help and to let individuals know of financial assistance programs, and also to be able to help them to build their financial responsibility, help them to know what it means to be fiscally responsible. And then as individuals who are working in this particular area, you have to be committed. Know what it is. What is affordable housing? Housing is everybody's problem. It's not just your problem or my problem, but it's everybody's problem. We need champions and coordinators for consistent community coalition building across all sectors. So we need dedicated staff for coaching and empowerment as we talk about affordable housing for Black women living with HIV, and then having sustainability, using those HOPWA dollars for supportive systems to fund continuing staff, hiring staff to help clients facilitate and meeting these coordination of programs. As we continue with this, it is important that we have the interdisciplinary care coordination as we deal with clients, Black women with HIV, and this includes having what we call a patient-centered model, patient-centered strategies. And there are two fundamental principles of a patient-centered model or patient-centered strategy. One is all individuals in this context are impacted by their health, and two, all people know what they need to be healthy. Patient-centered model is this model of provision that treats the patient or the client as the expert in knowing their well-being. And in this case, for Black women, it's a term of what myself and another colleague at University of Washington, Dr. Rachel Chapman, has called Black authoritative knowledge. And this includes having knowledge of, Black women having knowledge of their own physical and emotional wellness and the social determinants of health that can impede on their health, but when addressed, they know how to improve their own health. And these are the elements of that the interdisciplinary care coordination. As we talked about that, a key element of that is peer and patient navigators. And we see here that the four aspects of peer and patient navigators is to provide, promote, to help, and they also have that lived experience that can speak to the relational concerns of Black women with HIV, which helps with the stigma, the fear, the discrimination, and the lack of social support that so often Black women with HIV who are entering the healthcare system or who are trying to navigate the healthcare system have. And so briefly, I'm going to go through a project that I led that helped women that I led in the metropolitan Atlanta area, where housing was a major need that was identified, and how we were able to deal with that issue. So this was a project. Clients served were 114 Black women in the Atlanta area. The mean age was 40.2 years. When we looked at the individuals had to be at least 18 years old and identified as Black. Individuals had to be eligible, you had to have fallen out of care for 6 months or more, loosely engaged in care, not virally suppressed, or have at least 2 comorbidities. Patient navigators would check in by phone or electronic communication or in person, and navigators assess the patient's mental health, their housing, their food, their income, their employment needs, or other potential issues with substance use, or any other potential needs that the clients would have. And this particular project lasted from January of 2017 to November of 2018. So we see here in terms of demographic, in terms of some demographics, we had 43 women out of the education, 37.8 reported a high school education, 28.9 reported having there's 37.8 reported a high school education, including more than a high school education, including some college graduate or post-college. 28.9 reported having a high school diploma or more. And then here we also, you can see what the health insurance status was. Now, when we look at Black women's, their expressed needs, behind transportation, 47% of the women reported that was the second highest need. And here was a quote from one of the clients. "I'm tired of living in this boarding house. I need a place, even if it's a one-bedroom. I'm able to pay so much every month because of my disability check." But as we look at our outcomes, 86.6% were linked to care within 90 days of post-enrollment, 92.6 within 120 days, 93.9% were linked to care within 180 days post-enrollment, and 86.6 were linked to care and retained in care at least 12 months after enrollment. As we look at unmet needs, and these are unmet needs versus express needs. So we saw that unmet needs, express needs were 47%, but here we have the unmet needs. So our total unmet needs at baseline was 63%. At 6 months, they went down, and then we have at 12 months, they were even lower. So based on this, as time went on and women received care, met with their patient navigators, the actual unmet needs decreased. And this is a chart of the viral suppression, how viral suppression actually improved over time. So in terms of our lessons learned, again, we need champions and coordinators for consistently community coalition building across sectors. It's important to have social support and networks, dedicated staff for coaching and empowerment. Patient navigators help improve Black women with HIV, reduce unmet needs such as housing. They provide us a strong system of support. They help address the basic needs first, such as housing, transportation, and food insecurity, and then they focus on those care assessments. Because one of the things that we have found is that if you don't address the basic needs first, then it's hard to get to addressing the retention in care and the viral suppression. And they provide this connection to resources that support Black women for long-term coping. Also, it's important to treat the whole person. These are one of the things that we talked about, and once again, because Black women are more than viral loads and CD4 counts, and treating HIV as a system of structural and systematic issues that make Black women more vulnerable to HIV acquisition. So overall, we have to provide culturally relevant care and practices. These are my references. Thank you.
Again, let's give our speakers a round of applause. There was a slight change, but it's not reflected in my slides right now. But that's okay. We will keep moving forward. I'm going to change it up a little bit. We have again, as I shared earlier, we have an exciting panel ready to share more information with us. And I'm going to allow them to introduce themselves as I'm going to go through all of the panelists' names and what entities they represent, and then they're going to pass the microphone and give a brief summary of their areas of practice and what they want to highlight before we go into the question and answer session. So first is Dr. Maisha Standifer, representing the Morehouse School of Medicine. Next is Dr. George Nawas, Xavier University of Louisiana. And you guys, before you speak, you'll read the disclosure statement, okay? Because again, we edited the slides, but somehow they reverted back. Magically, we have things happening in this room. All right, and Ms. Gina Brown is representing the Southern AIDS Coalition. Ms. Allison Belton is also representing Morehouse School of Medicine. And we have Dr. Lakeisha Williams representing Xavier University as well. So I'm going to go back to this disclosure statement. Everybody's going to recite it now. You ready? Yes. Okay, hit it. Oh, you can't see it? Oh, my God. Okay, you can't see it because the slides are out there. Okay. So I'm going to read it for them. All of them, for this educational event, they have no relevant financial arrangements or affiliations with any corporate organizations to disclose. Okay? And here we are. This is the list of panelists. Again, we can't see the slides because they're out there. But I'm going to allow us to pass the microphone. I'm actually going to sit and moderate, I think, because that's going to be weird getting up and down. Again, rebounding. All right. Without further ado.
Thank you, Dr. Riley. I am Aisha Standifer, representing Morehouse School of Medicine. The disclaimer statement has been read, or you've seen it, so thank you so much. And so I'd just like to highlight a little bit, and we'll pass the mic, a little bit about what I do at Morehouse School of Medicine and Satcher Health Leadership Institute. Some of you may have heard of David Satcher, and it's a great opportunity to represent the Institute and represent him. He's a former 16th U.S. Surgeon General and former director of the Centers for Disease Control and Prevention, also former president of 3 of the HBI medical institutions at Morehouse School of Medicine, also Meharry and Drew. So we're excited in terms of what he's established in terms of leadership, development, and training institute for the future public health and medical educators. And so why not house a leadership development hub, we want to call it, at a premier HBI medical college? And so when Gilead Sciences approached us, it was a great opportunity to state, hey, we have low-hanging fruits, HBIs, in areas that have been disproportionately represented in terms of not just the area that they're situated in, the state that they're in, but the population that they serve. And when the graduates leave that institution, they go and service those particular institutions that we are talking about today. And so we partner with Gilead Sciences to focus on ending the epidemic in the U.S. South. We have our partner with Xavier University College of Pharmacy. And so we have a number of particular components that we highlight. We'll talk a little bit about this on the panel, but I just want to highlight that we are focusing on data science, developing the future generation of data scientists, but also creating equitable data solutions and how we represent us, Black women, hetero Black men, people don't talk about. So a number of populations that we need to highlight for those that often aren't voiced or even seen. Right? So we're uplifting the data and amplifying this message. We also are focusing on, which future Dr. Belton's going to highlight, a little bit about the training and curriculum development, and we're also educating policymakers, because we have to understand that political determinants of health, I don't know if many of you have heard of that, but that pushes the social determinants of health. So we really need to understand where we're situated when we're talking about Black women and policy decisions that are made for us but not by us. And then I also want to highlight in terms of asset mapping and storytelling. That's what we have. Our task force members, who I have our member in the back, our program manager, Evan Martin, leads the task force, that we would not be here today if we didn't have those who are living and fighting and activating a conversation conversations in the spaces that we sometimes can't touch as academicians, right? But we have to understand that those people who are going day to day, living with that diagnosis and fighting the fight are there, and they're representing their voice. So we are community-centered in this particular project, and then we also need to highlight in terms of surveillance and data collection. So I'm excited that we're going to talk a little bit more about that today.
Thank you so much. Next, Dr. Nawaz.
Thank you, Dr. Riley. Thank you, Dr. Sandiford. We're still morning over here, so good morning. My name is George Nawas. I'm a clinical associate professor at Xavier University. I teach our students, pharmacy students, infectious diseases therapeutics, and I focus a lot of my research and my work in HIV. So I'm an HIV specialist as well, very passionate about HIV and exploring health disparities in general. I'm serving currently as the policy team lead at the Louisiana Can campaign, Louisiana Can End the HIV Epidemic, and you're going to see a booth out there with amazing merchandise. Make sure you pass by there and get you something. I have had just to give you a little bit of a brief overview of what we can talk about today as what we've been working on lately. As the policy lead in the HIV task force of this collaboration that Dr. Standifer was talking about. Political determinants of health are very important, and I agree with Dr. Standifer that they drive every other thing, especially as it relates to decreasing the disparities that we see in front of us. So lately in Louisiana, I'm extremely excited to be sharing with you that a piece of legislation passed recently in Louisiana, which we supported under the leadership of Dean Kennedy at the College of Pharmacy. We supported this bill that recently passed in Louisiana that would expand the scope of practice of pharmacists in our state to be able to initiate HIV prevention. So we're very excited about that. We're very excited that the pharmacists are stepping up right now in order to try to decrease our acquisition numbers, to decrease our, or to improve access is what's very important in this situation, because we know that, and we can go into the statistics because I'm a scientist and I know a lot of you would want to hear some more numbers, but there's a big health disparity that we see. A lot of people who are impacted by HIV in our state do not have access to these medications, and by this significant milestone that our state is passing through, we're very excited that we are going to be supporting the training of pharmacists in our state as well, to be able to go out there, find the people who need these very highly effective and safe medications, and give them the access, get them connected with a healthcare professional if they don't have one. Make sure that they're not worried about having to pay for something if they can't, because we don't want their access to decrease just because they can't afford it. So we are extremely excited for this, and I had the pleasure to serve on the state-level advisory panel that promulgated the rules of this legislation. And we're very excited that it just passed through the public comment phase with not a lot of opposition, so we will not need a public hearing, which means that we are about to get this law enacted in Louisiana as of late April and early May. So we're all right now rushing to try to train these pharmacists in Louisiana to be ready to go out there and make a difference and try to find those who are impacted and try to catch them before they acquire HIV by giving them what they need and empowering them with HIV prevention. Thank you.
Good morning. I know it was said that I'm here for SAC, Southern AIDS Coalition, but I'm really representing two organizations. One is called EPIC, is a coalition of cisgender women living with HIV, and a Reunion Project, which is a long-term survivors project that we're doing. It's a national organization now. And I'm Gina. I am a woman living with HIV. Next month on the 4th will be 31 years. that's the thing that brought me in the room. What keeps me in the room are women who look like me, who don't have the resources that I have. I've been blessed. I was able to go back to school and get 2 degrees. I have a really good job, but I'm still living with HIV. So I make sure that when I'm in community, normally I wear red chucks, but I was like, that might not be appropriate here. So I didn't wear them. But I wear red chucks because I did an interview years ago where I talked about my red chucks. So when I'm in community, people still come up to me and they'll say, you that HIV chick, huh? And I'll say yes. And then we'll have a conversation because it doesn't stop at 5 o'clock. And I came in the room and I was like, only people I know is Dr. Kennedy, Dr. Nawaz, and my good friend Xula right here. I was like, that's all I know. But y'all started talking. You talked about sister love. I know Dejan very well. I am a leading women's society member for Sister Love. You talked about housing. That's my passion. I was the unhoused case manager at Noise Task Force for 4.5 years. So being able to work in community with people and think about housing and really be at the table is huge. Then when you said housing is healthcare, I almost fell off my chair. I was like, yes, that's it. Because it's also prevention, right? Yes. And we have to say that. You talked about Dr. Satcher. I leaned over and I said, that's my boyfriend. I've loved him since he was a Surgeon General, and I've been able to meet him a couple of times, and it's just been amazing. But I really want y'all to know that HIV has changed in a lot of ways. We're talking about it publicly, but the stigma is still there. There are still women who, when they get their diagnosis, they go underground. You know, we can't forget about them. They disappear. And we have to find and we have to engage with them. You know, when y'all were talking about PrEP, I often think about this. I had an opportunity to go and work somewhere, and I didn't go because I felt like black women in PrEP was not their top priority. And I know how HIV impacts women. Most of us are caregivers. I was diagnosed in pregnancy. You know, I took a test before pregnancy and it was negative, and I thought that once you got a negative, you were negative for the rest of your life. And the only reason I took another test when I was pregnant is because Charity Hospital rolled it in to everything else. It wasn't a standalone test. It was, we're going to test for this, HIV, this. And I was like, okay. Never thinking that HIV was a part of my life, you know. So I'm really happy to be here. I'm not going to take up a lot of your time. I'm sure you'll get to know me as the panel goes on. But I really want you to remember that National Women and Girls HIV/AIDS Day is a day that we're celebrating, but too many people don't celebrate it because they don't see black women or women, period. So thank y'all for being here.
Wow, tough to go after that as well. Good morning, everyone. Lakeisha Williams, Clinical Associate Professor at Xavier University, also serving as Director of Community Engagement and Outreach for our Center for Minority Health and Health Disparities Research and Education. I know it's a long name, but it's very powerful in regards to the work that is being done. Also a clinical pharmacist by training and just really passionate about the community. And so what I do, just thinking about before I got involved in academia, community was always my passion. And being able to do the work in my church and being able to do work that a lot of people didn't want to do at that particular time. So taking the information that we hear, taking the information that we learn, that we're educated about, and being able to bring it to the community, being able to make sure that the community is empowered with the information that they do know, and also making sure that the community has a voice and a seat at the table. And that's very, very important. Now, I know we're going to talk a lot more about that as it relates to community engagement, as it relates to being able to develop community programming, but just making sure that we're able to hear that voice from the community, that the community is involved in everything that we do, whether that's prevention, whether that's treatment, whether that's development of different training training opportunities, educational opportunities, and involving those that are all involved. So I'm really excited to be here to talk about a lot of the initiatives that we're doing at Xavier University. I know my colleague, Dr. Nawaz, mentioned Louisiana Can. We also have a new initiative, I Love Me, that focuses on educating Black women and girls, a new initiative, and so just really being able to get the word out there and meet people where they are so that we can end this epidemic. So thank you all so much.
Good morning, good morning, good morning, everyone. As Dr. Riley mentioned, my name is Allison Belton, and I am the Director of Education and Training for the Satchel of Leadership Institute at Morehouse School of Medicine. I'm glad my colleague, Dr. Standifer, went through the whole spiel on our history, so I don't have to go through that. And I'm very, very happy to be here on this panel with some new faces by way of Ms. Brown and Dr. Riley. Dr. Heath, I can't call you new face because we were seatmates yesterday on the plane. And of course, Dr. Williams and Dr. Nawaz, they have been our partners in good in the epidemic project with Gilead for some time now. So, you know, they're family. But thank you all for having us here today. I am a public health practitioner by training. I have a background in health promotion and behavior, but I have a passion for training others. I have a passion for education, whether it is educating others on how to have healthier lives or educating others on how to help others attain healthier lives. And I appreciate being able to do so by way of community-based trainings, working with those within the community, for the community, and with the community. And so I'm very happy to have this opportunity to talk about one of our training initiatives that is tied to our In the Epidemic project, which focuses on training organizations as well as leaders within the community, those who serve individuals who are living with HIV, and how they can better serve these individuals and the communities impacted by HIV on various elements to help reduce stigma and help mitigate these barriers and inequities that are impacting these communities. And so, you know, we'll get into more about what our training efforts have been in this space, as well as what we are doing collectively through our projects, and how this is a translatable effort. While we are focusing in a general sense on people living with HIV, of course, this is translatable to work with specific populations, whether it's working specifically with women living with HIV, Black women living with HIV, Black girls living with HIV, and just learning and growing in our efforts to just overcome and change the landscape of what is occurring, and just making this more optimal for communities as a whole. So glad to speak with everyone.
All right, so I hope everyone can see and hear all of the panelists, and as we move forward into this conversation, again, they have shared already a little bit of their background, so I'm excited to dive into this conversation. So I live here in New Orleans now, although I work out of DC, and we recently received our 2024 STI report, talking about how we, in terms of STIs overall, chlamydia exceeded both state and national averages. And although we were proud of our HIV numbers reducing, we saw a surge in young people, particularly those aged 15 through 19. And so we're here talking about Black women and girls, but we cannot forget the girls, okay? So my question I was targeting everyone. I had individual questions, but we're so intersected. You know, all of our work relates to what the other is doing. So I'm going to ask this question, and all of you can then share what strategies and collaborations you've developed through your research and your projects that will impact not only Black women, but then also empower our clinicians or other entities to also reach the youth that aren't even talking about sex publicly, but from the numbers we see that they are having unprotected sex. So I'm going to start with the panel first, and then we'll go to our keynotes as well, okay? So I'll pass it to you first.
I will start. So we have a number of, we call them opportunities, and I guess we can call them tools or strategies as well. But opportunities, because the Morehouse School of Medicine, with the foundation is the community health model. What we are working with, and I was just in conversation last week when we held our implementation science workshop to focus on HIV, to develop HIV researchers. What do we need to do, again, to focus on K through 12? That's a big factor because of the restrictions on what you can do in schools. There have been some successful ways of going about and going around some of those particular restrictions, and I know that we've talked with Boys and Girls Club. There have also been some efforts with, I know Girl Scouts are doing certain things, so we've had to kind of shift and maneuver. There are some of our task force members that are allowed to go into certain schools and talk about their experiences, and so we're excited that we're making sure that we amplify the messages. What we can do, though, is that we focus on undergraduate institutions. You talk about the 15-year-olds, but it's also high in college age. And we've worked with the Atlanta University Center Consortium and their Wellness Center, highlighting that when they have orientation, freshman orientation, that they have some first-time diagnosis from those coming from high school. And they offer testing. So they're saying this is evident of what needs to be, taught throughout the nation. But really, when they come to, the HBCU system that we have here in Georgia, what do we do then, right? We've also had athletic directors come and state, can y'all talk to these young men? Because they're coming to me and I don't know what's going on, what's happening. So I've talked with some individuals to say, hey, what can we do? Because we know there's a need, but we need to really, again, factor in, well, how do we do this? Because it's so expansive. You talk about sexual health in general, but then when you talk about sexual health, you also have to talk about mental health, because we talk about whole person. It's not just that diagnosis. So we are looking at very specific kind of holistic programs that we're working with for college age, undergraduate institutions. So we have some programs that we're working with. Really also, we are looking at developing, we have an HBCU season, kind of the party season, and how we're going to really work with our institutions in urban Atlanta, but we not just focus on urban, we go into the rural spaces. Because there are 4 other HBCUs in Georgia that are in rural spaces. And we cannot exclude rural because along outside of Atlanta, 70% of Georgia is rural. So we have to go down this 75 corridor that you have these pockets that we work with people in Albany State, Savannah State. We're going through Payne, and we're also going to Fort Valley, that has high rates of HIV, what's going on, because it's kind of staying in these pockets, not really going far. So we're making sure that we're targeting and really directing our focus on that population, working with those trusted resources, whether it be their wellness center, whether it be some of the gender affirming programs that are in these spaces as well, because we also have an increase, especially in rural spaces, with gender affirming churches, and also some nuanced pastors and preachers that, they're no longer antiquated, old style thinking, but now there are generations that have gone through this epidemic. And so there are 40, 50-year-old preachers that are saying, come on in, and welcoming in Macon, Georgia. So we plan to go there. And again, we have another program that we're focusing on in classics. Some of you know about some of the classics I'm sure that they have down here in the HBCUs, but we were down in Columbus, Georgia, where people said, hey, please come and talk to people. We'll have a tent in our classes. So making sure we're targeting and being culturally responsive and tailoring some of those messages is very key. And then when you talk about just students in general, and then you're able to get to some of those specific populations like Black women. And just to highlight, we are training our students, our residents, and our clinicians. And this has been an effort with Vive has kind of come in the space, and Dr. Dyson, I don't think she's here, but Vive has come into the space. They said, let's train the doctors. And so we now have a space every other month in the grand rounds at Morehouse Healthcare, where they're coming to talk about the state of HIV in the Black community, state of HIV in Black women, what do we need to do? And so we're developing a toolkit where we are targeting specific populations for clinicians to really work through and develop. So we're excited about that.
That's awesome. Thank you. I'm going to pass it down.
When I think about just in general, how can we reach that particular population? It's definitely going to be a multifaceted approach. And so we've really been thinking of different ways of how we can be creative in being able to meet them where they are. We first started with, and just looking at Xavier in terms of some of the initiatives on campus that we wanted to do, being a Catholic institution and seeing where we have come from and where we are right now. And so when I look at overall the course of timing, we've had the opportunity to really be able to hear from the students and being able to see what were some of those continuous barriers that we were seeing and what they were facing, and then how can we make sure that we meet their needs where they are. So within the last year or so, we've had the opportunity to hear from them and develop more increased awareness around testing and just being able to provide that access to testing. And so this is outside a lot of just the health observances and the HIV observances, and just really being able to say, hey, testing is available. It doesn't necessarily have to be linked with a health fair, or it doesn't have to necessarily be linked with a specific day, but whereas they would feel comfortable being able to obtain that testing. So we've had the opportunity of collaborating with a lot of organizations that focus on testing, that focus on prevention, and this has really been a great opportunity to increase that awareness among the students, but also increasing that access. We've tagged it along with what we call Real Talk Thursdays in regards to being able to provide information about HIV and some of the other areas that you all mentioned in terms of that intersect with that, mental health, taking care of your health, all of those different aspects, and bringing in so many different experts and speakers that can really be able to be relatable, and where they will have a safe space where they can be able to have that opportunity to be transparent. And so that has been well, and I know we've been going well and really being able to expand those opportunities, but more so seeing those stats and a lot of what has happened in Louisiana, whereas we no longer have sex education, and we no longer have that opportunity of being able to talk about it in the classroom. It has really been a challenge in seeing how we can all collectively come together. And so that's where we are right now in regards to knowing that it's going to take everybody collectively to come together to be able to see how we can do that. Not only in regards to to being able to incorporate that population, to hear from them where we need to meet them, and especially now we see with social media, we see with so many different other aspects, and just really being able to involve them. So now we've been thinking about and developing some programming within our elementary and high school. We're in the process right now of developing some presentations that will be very, very relatable, layman's term of not just talking about sexual health, but being able to involve overall health, and intersecting and having those conversations about that. And I think when it comes to that particular population, is a very, very unique population. I think about my daughter, that's 17, and just really being able to have some of those conversations, and how can we have the conversation is what we've really been thinking about from Xavier's perspective in terms of seeing that approach and how we can be able to meet them where they are.
So one of the beauties and benefits of our HIV health equity training that we're putting on is that we're able to reach a wide audience. And so our training is broken into two different types of training. We have a health equity leadership development program, which is a nationally based training. We recruit from a national group of individuals who can apply for this program, apply to be participants. It's conducted virtually, so we're able to reach people from all of our states, territories, wherever you hear about the program, you're able to apply, be accepted if you're upon being competitively reviewed. Our second component is our organizational workshops. We're specifically targeting those within the states of Georgia and Louisiana. So we're reaching audiences within the rural and urban areas for those two states. So we have a nice swath of leaders, we want to call those learners leaders, that we can touch upon in order to go through our trainings or our educational basis. So I want to start with that. Also within our trainings, who we're touching upon, who we're working with the medical providers, the future medical providers. So it's not just limited to physicians, but also nurses, social workers, physician's assistants, those who are within any type of clinical setting, also those who are social service providers, those who are working within the community, so health navigators, those who have been working within community organizations as well, and also those who are policymakers and policy influencers. So we have those touch points that can reach specific audiences. So how that comes into working with girls in particular, that can be an audience that's reached through those particular individuals that we're recruiting or that we're looking to participate in our programs. And so when we look at our curricular elements that we touch upon, one of the specific curricular elements that we have within that covers across our training that I think about as it relates to that particular population would be one, combating stigma and barriers within the community. So that's one area that we touch upon through some various topical areas. And then also looking at coalition building and sustainability. So bringing in other organizations to help work on different approaches for prevention, for education, for being able to work with a population of youth, young girls and adolescent girls from elementary age to high school age in being able to support better health outcomes for them as a whole. And I do agree with what Dr. Standifer was saying. Not only do we need to approach the physical health elements for them, but we need to approach those mental and behavioral health elements as well, because we are seeing a great deal of changes in the behavioral health outcomes of young African American adolescent females as it relates to suicide and suicide ideation, as well as with substance use, and also rates of depression and anxiety. So we have to approach all of these areas to gain an understanding of this population, as well as work towards additional prevention efforts to ensure that they are healthy at the states that they are now, and then help them to become even healthier women as they continue to grow. And so within our training efforts, we're working with these individuals who will have various touch points at some point in time. And one of the things that we pride ourselves from the development of our educational programs, and Dr. Williams, Dr. Nawas, Dr. Standifer certainly were a part of that, Dr. Kennedy, and Mr. Martin's gone, but and members of our task force as well. It is a community-based program, so it was developed with the core tenets of community engagement in mind. So it was not something that we just felt needed to be involved. We didn't take, our pedagogic approaches that we know and have been trained upon to develop this, but we also took into consideration the tenets of MIPA, so meaningful involvement of persons living with HIV, and we also took into consideration the needs of community. What are those areas and elements that would support what communities need and would see? And so we knew that by working collaboratively with various groups or individuals who represented various groups and different spaces that had that common interest, we knew that would be an enhancement. So all of these things informed what we were doing in our training as well. So that's how we knew that that was an area that we could approach as well.
Say something. I'll be quick. Thank y'all for everything you're saying. One of the things that we realized, I'm with a group called PWN, Positive Women's Network, and we realized that women don't really know how to talk about sex, right? Mm-hmm. So we started having conversations with each other, teaching each other how to talk about sex, because we all had daughters. And I can tell you, growing up, my mama told me, don't get pregnant. She didn't tell me how you get pregnant. She didn't tell me how you prevent from getting pregnant. She just said, don't get pregnant. And I was so confused. And when I had a daughter, I realized, even as a woman living with HIV, that I had to educate her in a way that this doesn't become her life. That she had to know some things that were real. So I didn't sugarcoat anything. As we talked about condomless sex, we talked about condoms, we talked about all of these things because I wanted her to be healthy. And that's what we have to do. Where women are, we have to meet them where they are also, and make sure that they know how to talk to their daughters. It's not going to always happen in a classroom. And it all depends on who the educator is, because there's educators that can give our children the wrong information. And we don't want that. So I think it really is really important to come from the home or from a trusted adult in a child's life. I'm not saying that everybody should be having a conversation with everybody, because we know that's not a good thing. But if you're trusted and you know how to talk about sex. When my daughter was 13, I brought home the STI book. And everybody said, why did you do that? I said, because I wanted her to know what it looked like. I didn't want her to just be out here and not know what stuff looks like. And there are things you can't see. So we had that conversation too. But it was so funny when I brought the book home, And she was looking, and she was like, what's that? And I looked, and I said, like, where have you been? Like, a penis. And then she said, no, that. And I said, oh, his testicles. I said, we call them balls. She says, 2 of them? And I realized bringing the book home helped me to help her, because she was going through life thinking it was one.
Wow, I'm going to go after this story.
Keep it real.
Wow. Okay. Now that we all know there's 2. I think my fellow panelists talked a lot about how to reach this population. I just want to add one quick last statement here, is that at Xavier University, we're not only trying to think of how we want to reach to them, we also recognize that a lot of those black girls and black women are around us and on our campus. And we have an amazing opportunity to reach them, and they could reach their communities and their families as well. And it's been amazing being part of this work, because we had some nice panel discussions. We've had some town halls on campus where we encouraged everybody to get tested as part of a routine of their routine healthcare tests. And we encouraged all these black girls that attended to go to their physicians and just include it as part of their annuals. Ask for it from your gynecologist as part of what everyone is doing, so that it's not looked at as, oh, you're doing this because of you doing that. It shouldn't be like that. Everybody should get tested. So I remember last year we had an amazing event that I can never forget on AIDS World Day, where a sorority actually did this event, which was a very smart idea, because I was entering the room and I saw at least 100 black girls in front of me. So it was amazing, because I was able to speak with them as an HIV clinician who's focused on decreasing HIV disparities, and I knew that this was a golden opportunity to explain to everybody what HIV prevention is, and to empower them by knowing their status, and to go and ask questions and ask for their HIV test with their annuals. So that was an amazing opportunity there. Also, we've had amazing opportunities where Ms. Gina came to campus and spoke with women and girls as well. So we're making sure that we're having amazing people like Ms. Gina come over and be able to answer direct questions, and for our students to be able to see someone as amazing as Ms. Gina, who has passed through a lot with, since her diagnosis, and they're able to connect with her and ask her questions, so that they know what they should do to protect themselves as well.
You don't want to share what sorority? No, just kidding. I'm just kidding. Okay, let's stay focused.
I'm going to keep this short. As Ms. Gina was talking, one thing I wanted to think, we have to think outside the box. And as we talk about communication, thinking outside the box. So I think I said I wear many hats. So in one of that, I'm an associate pastor. And one of the things that one of the places that we did not talk, Dr. Standiford briefly touched on the church. So one of the things that, as we talk about women and girls, is communication, and one of those places that we really have to talk about sex is in the church. We don't want to talk about sex in the church, but in the beginning, Adam and Eve, they had sex. All those begots, you can beget if you didn't have sex. And so I, as a black woman, as an associate pastor, I stand in the pulpit and I talk about HIV, and one of the things that I really used to always talk about in terms of when I was a youth pastor is really have those conversations about sex. And I was very fortunate to have pastors that supported me to let me know that it was important to talk about sex and continue to talk about sex from the pulpit, because if we don't, then we're going to continue to have these conversations. And even in having communication as black women, we can't have communications in silos with ourselves, because we're not having sex with ourselves. So as we have communication, we also have to have communication with the men that we're having sex with. or the other women that we're having sex with. Whoever you're having sex with, you got to have communication with them, you know. So these are the conversations that we have to have, and I'll stop right there. Just have communication. Talk about sex.
All right. I'm going to also keep this brief, but I would be remiss not to mention technology and how that works. So some of the things I wanted to talk about with a lot of the initiatives that we're doing is around digital and social marketing. So we work with groups of women and get their opinions. So they're like our creative collaboratives, and we talk about like how can we create social media spots and create videos that will resonate and potentially go viral. Like we're always striving to do that, right? So that's one of the efforts that I think could certainly be far-reaching and to include girls. I also didn't mention that my lab is called the Queen Savvy Lab. So a lot of my work has the word savvy in it. So we do have Savvy Tools, which is like a toolkit that we're now testing where we created small snippets and videos, co-created those with Black women to talk about what PrEP was, HIV, also PEP. I know PEP doesn't get a lot of recognition, but we also are now testing that with another group just to see, okay, can we roll this out as a social media campaign, and how can we keep that going in the space of social media? Wanted to talk about college age, as I know I heard that mentioned. We have an active link right now with PrEP Savvy, and it's an entire curriculum for college age women around this. I also just kind of want to throw out some other like out of the box things, like can we partner with sports and coaches and couch it in the way of hygiene and complete wellness, right? Can we talk about gaming, like incorporating, like I try to keep up with all the tech stuff, so like NFTs and the metaverse and branding through those things in a public health way. So just really thinking about how we do, also performing arts, especially with younger kids, how do we role play and create programming in that sector? So like those are the things I love, like I'm passionate about, and I can't do them all, so I hope that you all will help in this realm, because I know there's creativity out there. I see all these young faces. So I'm going to leave it there.
All right, this panel, again, has several nuggets to share, and in our efforts to share all that we want to share, we've lost a lot of time. So unfortunately, we're loquacious, but it's a beautiful thing. So I'm going to tie this last question, and it's going to be kind of long because I'm tying it in two pieces, but it's where we are now. We live in a world that we've never seen before. And legislatively, we have seen changes that not only impact our access to reliable data and resources, but we also have to change our approach to patient care. So that looks at our educational tools, how we're training clinicians, even our publications and what we can put our names on depending upon our affiliations. What can we say? It's almost dangerous to say DEI anymore. So everything is tied to DEI. Even sororities are DEI now. So my question is, so I want to bring back Dr. Nawaz and what we're excited about in Louisiana, which again is we see this legislation moving forward, but most of the work started before. So we might have to trot another path. So I want to hear about the legislation, what steps this body can do, those in Louisiana and outside of Louisiana, because you're going to have to use those tools, you're going to have to use the strategies to continue to prioritize Black women and girls in HIV, all realms of healthcare. And then, for everyone else, how has this recent change impacted you, your patients, your research, and how are we going to make it through and continue to prioritize our populations? I'll just tell you really briefly, we have a community advisory group at the American Academy of HIV Medicine, and we were talking about the fear. Our patients tell us how to train our clinicians. And one of the members said to me, Angela, I didn't want to tell you this, but I'm saving my medication now because I might not have insurance later. Now, those of us that are clinicians understand with HIV medication, with treatment, you can't alter the therapy. But if the fear is leading you to make your own decisions, we then need to change how we approach those we love and the patients we serve, right? So I'm going to give it to Dr. Navas first because we want to hear about the new legislation and where we go from here now. And then everyone else talk about the impacts, how you felt, and what you're going to do differently so that we can continue to achieve the goals we discussed today. And we have, let me tell the loquacious panel, it is 11:28. Okay, and we want to conclude before 11:50 because we have a video to share. Okay. All right.
I'm gonna be
so when I give you the look.
All right, so I guess I'll just turn around this way.
Oh wait. Yeah. Oh. And we want to allow time for audience questions. So we're going to take that 11:50 back. We're going to go back to 11:45. Okay, and we also want to make sure we have the microphone for the audience. Do we now have that or no? Okay, so I'm passing the mic, new directions because we want to make sure we have allowed the audience to speak.
All right, what was the question? No. All right, so we're going back to talking about the important step that we are at right now in Louisiana. As Dr. Riley said, it was a perfect time for this to pass because we are at a time of uncertainty right now when it comes to HIV treatment, prevention, and all of that. So the timing was perfect. And what's amazing for us in our state here, I mean, there has been other states around the country that have advanced laws like this before, where they would they have expanded the pharmacist scope of practice in other states to include HIV prevention and sometimes prevention in the world outside of HIV as well. So there are states that pass such laws, but the problem with that is that a lot of those states that passed these laws, they had issues and obstacles that came up that did not allow these laws that passed to show any to show much progress in the world of HIV PrEP uptake. So we looked at these challenges in those states. We looked at those obstacles that they had, and we tried to understand what happened there that did not lead to this program actually making a big difference in their states. And we realized there were obviously a lot of obstacles, right? One of the big obstacles was that the pharmacists were already overworked and they did not have an incentive to go through extensive training programs to be involved in this kind of work. So what we did in our state here, and we're very proud about it and we're very excited about it, is that at Xavier University of Louisiana, we supported the legislature that passed that would allow the reimbursement of a pharmacist just like everyone else who prescribes HIV PrEP. So we're very excited about this step here in Louisiana because we know that that was a big obstacle in other states, and we're also working on training programs that are going to give them the conclusion of what they need to know to go out there and make a big difference and increase access to everybody. So there's lots of things that are about to happen. It's about to become enacted in Louisiana by the end of next month. So there are things that we're going to learn, but what we do know is that pharmacists are excited to jump on this in Louisiana to end the HIV epidemic, to improve access to those who are mostly impacted. And we are currently developing lots of training programs, some of them virtually, some of them in person, to allow a bigger number of pharmacists to participate in this so that they can go and actually reach the population that we're trying to reach.
Has it impacted your life?
I would say for our impact, we're all impacted. We're definitely all impacted from the training perspective, and I've even seen this in one of the courses that I work with at the medical school. Loss of resources, especially the online resources. It's not uncommon to go on, click a link, get the 404 bag gateway, this resource does not exist. So what we're doing with that is banking resources while we can. Just pulling things, PDFing, whatever we can do, we're trying to do that. The most poignant is definitely trying trying to just work with those, especially those that are coming through our training program, and they actually have just completed as of last month. But, you know, we had to go through that. I'm concerned about my job. I don't know what's happening, so we're just being in that supportive position. You know, you working with people for 12 months and they're in that training, you form relationships. And so really just supporting them through that and just shouldering some of that burden. We carry each other's burdens. I say that, and we are there with each other. But we try to bank our resources. We are working on finding alternate resources to support our trainings, and then, you know, also empowering our learners as well, because as you've gone through the training, you become a resource also. But the big thing is, you know, we're mission and purpose driven. This is not just something we're doing because we're funded to do it, but we're mission and purpose driven, and we got to keep going. So that's what we do.
I was going to add to that too, in terms of just keeping the work going. I know we've been hearing a lot from our community partners and organizations and our advisory board members that just have a fear in regards to, you know, what should be said. I may, you know, lose my funding. And we've actually had partners that have lost funding, like significant funding, where they're not able to continue a lot of the programming that they have been doing, a lot of the resources that they were providing to the community. And I'm also hearing as well that even a lot of the community partners don't want to partner with other organizations that have dropped the DEI. And so that's what we're seeing in terms of just a lack of trust, in terms of just a lot of challenges and barriers as it relates to that. But I know, of course, just in regards to adding to what you said, our mission is just to continue the work. And so regardless of what we may lack or what we may not necessarily have, being able to pull all of our resources together, being able to collectively and continue to work together so that we can be able to provide those resources to the communities and those individuals that we serve. And that's what's going to be very, very important, that regardless of what funding has been eliminated or decreased, that we just continue to make sure that we're making an impact and we're utilizing what we have to continue doing the work, to make sure that we are impacting and continuing to save lives.
The way the HIV community really was formed was through ACT UP. And we're ready to act up again. Come on. We know that this is our lives. You know, we have somebody over HHS who doesn't believe that untreated HIV causes AIDS. You know, we're telling our personal stories, but we're telling it to people who really don't hear us. So we have to do things differently. The HIV community is truly afraid right now. You know, they're thinking about the resources that they're going to lose. They're thinking about medications. They're thinking about their lives. You know, so I just say, stay tuned. As things progress, you're gonna see them. You know, you saw them during when they tried to take the ACA away. I was so proud of my friends. I saw them going to jail on TV. You know, I was so excited and proud of them, because you have to act up in order to get things done.
She talks about ACT UP, and you highlighted the 60th commemorative anniversary of acting up. Yes. And that is so key. And for the young people who were not there in the 80s, when you said, you know, we've been here before, not to this level and to this state. We were here before when the funding was taken away of a previous administration and people were fearful. The particular acts that are being done now are to evoke fear, purposefully, to cause chaos, and to cause you to want to pull back. Particularly, we're talking about the government. We're talking about those institutions, and it's not just HBCUs. We're talking about PWIs now that have lost funding. We're talking about grants that we've submitted that are now on hold, that are supposed to advance this. But as we know, we are a resilient people. We are a resilient institution. In terms of the HBCUs, we've always done the work and not been acknowledged. So we're going to continue to push through. We may have to shift it a bit. We may have to change language a bit, but we will get through. It's not going to feel good. We know that. It's not going to look good. but we know through the end, we're still going to continue to push through those tenets. That's what we do. That's how we act up. And we also, just to highlight, that we also have to think about the diaspora, and not just here in the U.S., because we've taken some of our training and efforts overseas throughout Africa as well. And as long as we can bring them as well, because they, we think that we are really hurting, but those who are abroad are getting the funding, and funding has been cut off. We really need to connect. So I want to just highlight, Dr. DeWaas, you and the team at Xavier have been excellent examples, and that's why in Georgia we are attempting to create that template. You have been on the webinars and aligning ourselves with those policymakers who are there. There are some, leaders that are there. They're fighting every day, and we know those HBCUs that are located primarily where we are have to be very strategic, but there are some fighters up in the state legislature from Louisiana, from Georgia, from Alabama. They're there putting their lives on the line and understanding who they're talking to when they don't mention historically black institutions. They just say historical institutions, purposefully, in legislatures. And you're looking like, oh, it has changed and it is changing. But I know that our leadership at our institutions are there for us. We are taking it and making sure that we're going to abide. The templates also embedding it in the curricula of, like you said, the PharmD students. You have a course. We're creating a course, hopefully in the MD student. I'm MD1. I teach MD1s. MPH students, we're doing that along with the PA students. So we're looking at embedding it into the curriculum to have it HIV and the black community in these spaces. So we're pushing and we're going through, and we have, leadership, and at least in our institutions, that are there for us. Anything else? Okay.
I'll be brief. I just think about our community as a whole and how we have been true activists. When you're born black, you kind of have to have that in your bloodstream. It's just no way around it. There is just periods of time where you're kind of in a space where it's not so intense, but it's always there, and then it's right in your face, right? So there's those times when you have, and we're in that time where it's just right in our face. I just think back to some of the activism that's going on. We command $1 trillion in spending a year, and we consume, right? Healthcare is a point of consumption, and so I don't have the answer, but what I will say is that I think that some of the efforts that are now going on with letting people know the power of our dollar, we have to maybe refocus some of that, and if we're shifting where that dollar goes so that it benefits the community.
Well, we again want to thank our panelists. We're going to move into the question session portion. Let's give them a round of applause. I don't know if we have a mic for our audience members, but if you have a question, please stand up. And I guess I can bring you. Oh, yeah. But this is for the panelists. They won't be able to answer. We're going to go back and forth with the one. Okay.
Any questions from the audience?
Yes. Yes.
Good morning, everyone. My name is Danielle Jathan, and I'm a senior majoring in biology, minoring in chemistry at Lemoyne College in Memphis, Tennessee. So my question is directed to Dr. Shanlo, and I saw that you showed there's a low percentage of African American women who are actually taking PrEP, but I know that in the healthcare system, African American women, especially black women on a whole, have been mistreated, which have led to a lack of trust. But what are the action plans? What are the strategies we're putting in place to make sure that we rebuild that trust, to make sure that they're using PrEP more?
Ooh, that's a tall order. I can't say that.
They're just going to go to the mic.
So you're not having to run back and forth. Give me a minute. I think that's a wonderful question. I don't know that I have the answer that, and I honestly don't know that we are actually achieving that. I think that there are silos of individuals trying to rebuild that trust, but it certainly is an effort that we need to work toward more intensely, which is why we're having these conversations. I can say what I'm doing, which is I'm having conversations with Black women, kind of seeing where that mistrust happens, and then how can we rebuild that? How can we communicate to them that they have the power? They have the power, right? They're consumers, they're paying for these services. So I hate that we have to, put the onus on Black women to demand it, because I mean, even myself and other colleagues who are well aware of the space will go in. I purposely go in and I'm me as a patient. I don't want people to always know that I'm a provider, because I should get the same care regardless, right? And so we're just trying to give Black women, unfortunately, at this point, it feels like it's the onus is on them. We're trying to give them strategies as to how to go in and require people to respect them as patients and to listen to them, because unfortunately, as my other panelists have said, we are invisible or people disregard what we have to say. And this happens in HIV and other sectors, because I work in the maternal health space, and we know that's a point of pain, right, for Black women not being heard and seen. But to your point, it's an area that we have to really work on, because we're not there yet.
And, sorry, just want to add one more thing to your question, because I loved it. It was a really good question. I think one of the things that, as a clinician, I see is Black women do not have this trust in the healthcare system. One of the reasons for that is I think that there's not lots of Black women who are on the other side who are giving the care. So at an HBCU, we're making sure that we have women, Black women, going out into the HIV task force, going into the HIV spaces, so that Black women, Black girls are able to see people who look like them and trust the treatment that they are given.
Good morning, everyone. I mean, thank you so very much for really a powerful, powerful panel and presentation. My question is kind of twofold, and I think it was referred to, I guess this idea that global health is local health, in the sense that in women, in terms of disparities, global health disparities versus women, or local health disparities against women. So I guess my question is, from this global health, this local health perspective, how are we making sure, to your point, that we're connecting this in a very real way to the diaspora, number one? And then secondly, when we talk about Black women, Black women are not a monolith. We are not,
It's okay.
It's not a monolith. And so I think we have to be very careful about when we make that decision of Black women, because again, what image comes to your mind when you say that? And so the last thing I would say is be very mindful of our own stigmatization. Like sometimes we can stigmatize ourselves unknowingly by using language and epistemic frameworks that others have imposed upon us. And then with new immigrants that come to the country, they're a vulnerable population, especially the women. Who come from different parts of the country, from the world with different cultures. They don't have access, and so be very precise and focusing on immigrant women, especially from the diaspora. Thank you. That was a lot, sorry.
So that was a lot, and I want to thank you. I thank you how you couch that, because it leads into a comment that I wanted to make to your response. Because you were said, and I don't want to misquote you, because you said Black women are not. No.
He was talking about
Black women does not have mistrust, and I was saying, and my immediately I said, no, I have mistrust, so you can't speak for Black women. And then you said Black women are not a monolith. And so that's why I was saying you can't speak for all Black women and say Black women don't have mistrust, because I have mistrust in the system. And it kind of goes back to say, depending on where you come from, You know, that kind of goes back to what you say, depending on where you come from, depending on your social location, depending on how you enter. As Dr. Chandler said, when she goes to the doctor, she goes as a patient. Most of the time when I go to the doctor, I go with blue jeans and a hoodie on. They don't see me as Dr. He. They see me as somebody with blue jeans and a hoodie, and they're like, you don't know what you're talking about. And so I don't have mistrust in the healthcare system. I'm just seen as another black person coming in who doesn't know, and then I have to say XYZ, this is what, you know, so it is. And then as you say, if you're not US born, then that's another whole layer in terms of health care. So there are so many different layers. If you are a person of color, a woman of color, if you're African born, if you are Caribbean born, or so forth. So we cannot stigmatize, label. We don't know what someone's social location is. We don't know what their issues are. You know, when they get there and they're 15 minutes late and you say, oh, you're 15 minutes late. Well, you don't know that they had to wait on someone to come pick them up, or the bus was late, or the babysitting didn't come, or whatever the situation was. The reason why there was 15 minutes late, and because they got there at 11:31 as opposed to 11:30, then you had to cancel their appointment, and then you say they have to come back again, and they already took off of work to get there, and they can't get another appointment for another 3 months. I'm sorry, I digress.
Come on, preach. Come on, preach. Yes.
But yet we don't mistrust. And then, because they can't come 3 months later because they don't have any more sick leave because they already took off because they were taking care of their mama, their grandmama, the 2 kids, and everybody else, you're going to say they're not adherent. I'm going to sit down.
So I just want to comment on that. Thank you for those comments, because I think you even had it in your slides when you talked about cultural sensitivity, cultural humility. All of those things have to be taken into consideration. Everybody is not the same. You know, those from immigrant women that he mentioned, everybody you have to look at people differently, and you have to be able to understand their background. That's why we're talking about those social determinants of health, the fact that you don't have transportation to get to wherever you need to go. You may not have the housing. All of those things are important, and that's why we're talking about, you know, collaborating to make sure that we come up with sustainable solutions. So thank you very much. I don't think we have time for any other questions, so we're going to turn it back over to our moderator, Dr. Riley, to conclude.
Thank you again, Dr. Kennedy, and our panelists. Let's give them a round of applause. And thank you, audience, for being engaged with great questions, because the conversation doesn't end today. We're just opening the conference. Can you believe it? So again, hold on to your hats. It's going to be a great one. Now, we're at the portion where we have to assess your understanding. So again, take out your cards. Unfortunately, the slide is not in here, so I'm going to have to read it to you, but work with me.
It may be. Did you go?
It was updated, but it didn't update here.
Okay.
Unfortunately, let me see.
Okay.
No.
Okay.
Okay, so here we go. Bear with me. Everyone have their cards? Yes. All right, here we go. Viral suppression is the lowest in women who are A, homeless, B, temporarily housed, C, stably housed, D, unstably housed. Okay, and you can raise your card. Again, we listen and don't judge. So, everybody? All right. The answer is B. And we will use time later in the day to talk about the answers we just saw. Okay, and the answer was C, stably housed. I'm sorry, C, stably housed. So C, okay? Yes. And the next one, which of the following is an example of interdisciplinary care coordination that can be utilized for Black women with HIV who are homeless or unstably housed? A, person-centered care. B, social support, coaching, and mentoring. C, housing assistance services. D, all of the above. Okay, thank you. Okay, the answer is D. Yes, okay. Number 3, how does Act 711 aim to improve access to HIV prevention services? Act 711 was discussed earlier and recently again. A, by mandating that all private insurance plans fully cover all HIV prevention and treatment medications without restrictions. B, by authorizing pharmacists to independently prescribe and dispense HIV PrEP and PEP under a statewide standing order, ensuring wider accessibility. C, by requiring all hospitals and healthcare facilities to provide free HIV testing and counseling services to all patients. D, by imposing stricter regulations on HIV medication prescriptions to limit misuse and overprescribing. All right, everyone, great audience, great. Thank you. The answer is B. And finally, number 4, a core tenet of developing translatable community-based training for HIV service providers is A, setting plans and intentions prior to obtaining community input to set an agenda and control efforts, or B, working collaboratively with and through groups of people affiliated by some common interest or situation to address issues affecting the well-being of those people. No, keep going. You can raise your voice. Okay, it's okay. We don't judge. But the answer is B. The answer is B. So I'm going to share the QR code for the accreditation of this session.
Yeah, it didn't upload.
And unfortunately,
Yeah.
the video is not in here. Unless we're able to update the slides really quickly. Do we have that Dropbox link here with the updated slides? Is my Joshua Group person here? No? Okay.
If you go out and
If I go out and come back in?
Maybe
Okay,
it's
let's go
there.
out. Okay. Is it in a Dropbox actually? Oh, here. Okay, here's the updated copy here. Uh-oh. Of course, I'm having difficulties because I don't have a mouse. There we are. Okay. And of course, the questions will be, everything will magically appear like we wanted it to after I've read through everything, but that's why we're here. Oh, Lord. Okay. Yep, the questions are there.
You going, oh, okay. There's the video.
Okay.
What's up, Louisiana? I am the one, the
Oh, it's
only
not
one,
loud
Jackie
enough.
B. And Louisiana can end the HIV epidemic through open and honest communication.
HIV affects all people in all sexualities.
And if you're having sex, you are HIV possible.
Let's go. Come on.
Louisiana can end the HIV epidemic by increasing awareness, access, and promoting strong advocacy work.
And with Louisiana Can, we can work to end the HIV/AIDS epidemic.
And Louisiana can end the HIV epidemic by having those conversations, building those relationships of trust,
and having safe, consensual sex.
And I can't stop the rain from falling, but I love me. I love me, yes, I love me. Who's gonna love you when you're tender and you need some care? Who's gonna hold you when you're lonely? Someone who'll always be there. Come on, you gotta understand. Yeah, realize your value. You are worth more than you know. So grab yourself, smile. Vision clear. Say these words, said you can't stop the rain from falling, but I love me. I love me. I love me. Hey, it's a beautiful and I can't stop the rain from falling, but I love me. Well, I love me. Yes, I love me.
All right, so this is our social media campaign. I want to thank our media consultants, our Conic group, for putting this together. I got it like 1 o'clock this morning. I saw it when I woke up, and I wanted to share it at least with this group. Hopefully, I'll get a chance to share it with the entire group here. But, you know, the theme is I love me, and to focus on understanding HIV and talking about it among women. So thank you all for participating in this session today.
All right, thank you guys. Panelists, we want to take a picture. Let's get together and take a picture. I don't know.